Hello, everybody. My time says 5 o'clock, so I'm going to go ahead and get started. My name is Karina Pedersen, and I just want to thank you guys first for joining us at the Script Your Future Patient Education Webinar Series. Script Your Future is a student-led campaign that focuses on ways to improve patient medication adherence in the community. It also aims to improve upon and help manage various health problems. Special thanks to Jasmine and Kavita for putting this on and helping to organize and making the whole thing seamless. I really appreciate your guys' help and this opportunity to educate people on COPD. So that brings us into our next slide. So my presentation today is called Chronic Obstructive Pulmonary Disease. What is it and what can we do about it? Our objectives for today are first to describe what COPD is and who is at risk for developing the disease. Second, it's to discuss how patient life is affected by diagnosis. And third, it's to identify treatment goals and current therapies for COPD. So what is COPD? COPD is a group of lung diseases that are characterized by progressive chronic disease and inflammation that make it difficult to breathe. COPD stands for chronic obstructive pulmonary disease, and COPD and its progression are preventable. And we'll get into more details about this later. So COPD subtypes. So there are two forms of COPD. One is called emphysema and the other is called chronic bronchitis. And I'll be going through both of these today. Just to give an explanation. So first, we'll discuss emphysema. Emphysema is a progressive breakdown of the small walls responsible for gas exchange in the lung. So the way I like to think about it is pretending that, so this quite bubbly unit looking at the end of the lung is called an alveoli. And how I like to think of an alveoli is kind of like a Tupperware container. So think of that whole unit is a circular Tupperware container or a vase filled with a bunch of bubbles. So what happens in emphysema is basically those bubbles are what are responsible for bringing in oxygen into your blood and taking out carbon dioxide to exhale. So what happens in emphysema is that all of those little bubbles kind of break down, so that all you have left is the outside of the rim. So that really decreases the amount of surface area that you have to take in oxygen. That progressively leads to poor oxygen saturation late in the disease. So yeah, like I said, it's difficult for oxygen to be exchanged and removed from the lung. And if at any point anybody has any questions, feel free to put them in the chat. Yeah. So chronic bronchitis. Chronic bronchitis is swelling and inflammation and irritation of the small airways in the lungs. This chronic inflammation causes excessive mucus production, and after that, well, before that, the narrowing of the airways makes it difficult for air to come in and go out of the lung. So as you can see in this right picture, where it says a normal bronchus and then a chronic bronchitis, where it says chronic bronchitis, where you see this really thick wall, that's what is causing the airway narrowing. And for some reason, it's quite difficult to understand without getting really scientific, but this causes excessive mucus production. So in chronic bronchitis, often you'll notice an increase in sputum and kind of like a more of like a phlegm. Also, it's important to keep in mind when you have COPD, often it's a mixture of emphysema and chronic bronchitis. Often people get diagnosed with just COPD in general for this reason. So another commonly asked question is the difference between COPD and asthma. So to start, what we just went over, so COPD has an onset that's usually later in life. It is often caused by smoking or other pollutants. So we'll get into that in a little bit, but smoking is the #1 risk factor for developing COPD later in life. And exacerbations of COPD are often triggered from environmental factors. So I'll get into exacerbations a little bit later, but just to give a brief synopsis. So exacerbations of COPD is basically just means a worsening of your symptoms. So as I'll get into in a second, this often means having more shortness of breath, having more mucus production, and just general uneasiness, uneasiness feeling regarding breathing. And this is difficult to reverse. So unfortunately, as I'll also get into later in this presentation, there is a problem, or we don't have any treatments to actually reverse the disease. All treatments available are there to help alleviate current symptoms. And then, so asthma has an onset that is typically earlier in life, typically in children. However, it can be adult onset asthma, which is not uncommon, but typically it's earlier in life. There's also a relatively unknown reason why people get asthma. So it's triggered sometimes by allergies or things like that, but overall a very unknown reason. And asthma exacerbations, so worsening of asthma symptoms, are often caused by allergic reactions, or like, for example, if somebody has allergies to pollen and they step out in spring in the summertime, or they step out in outside in the springtime, they will often get an asthma attack, which basically just is a constriction of the airways, and it often requires hospitalization, or most often hospitalization. And asthma is also quickly reversible with inhalers. So you'll see people sometimes, like athletes, carry around an inhaler, and after their run, oftentimes people will just take a breath of their inhaler to reduce that airway constriction. But both COPD and asthma are obstructive lung diseases. There's different kind of lung diseases, but these both fall under the category of obstructive lung disease. Okay. So a couple of facts about COPD as a whole. COPD is the fourth leading cause of death in the United States. It was recently demoted to fourth, COVID being one of the top three right now. So previously, for several years, was the third leading cause of death in the US. And Ohio has one of the highest rates of COPD compared to other states. I tried to research this, couldn't find out much more information, but it does have one of the highest rates. And in 2019, COPD was associated with 3.23 million deaths worldwide. And most deaths from COPD are also from women. It is not known why either, but or I couldn't find anything in my research. So those are just some general facts. So some symptoms of COPD. COPD is most commonly, this first three bolded symptoms are the most common symptoms of COPD. So that is a chronic cough, so a cough that lasts a long time, can't seem to get rid of. Oftentimes it's shortness of breath while performing everyday activities as well. And coughing up mucus. So sometimes this mucus can be colored. It can be green, it can be yellow, it can be kind of rust colored. And all of those symptoms could be early signs of COPD. Other ones are frequent clearing of your throat. If you notice like a bluish tint to your lips or your fingernails, maybe you're feeling easily fatigued, or you're wheezing when doing everyday activities or on exercise, and that's not normal for you, and you experience chronic or you experience weight loss kind of rapidly. All of those symptoms, I would say, are reason to go see your physician, and kind of just ask about maybe if those are symptoms that are normal. So who is at risk for developing COPD? Smoking or exposure to environmental tobacco smoke is the #1 risk factor for developing COPD later in life. COPD can also happen from exposure to toxic irritants. So whether that be pollutants, chemicals, dust, or fumes where you work, or maybe you have a factory close to home that's putting out pollutants into the air near you, and you're constantly breathing that in. that can cause COPD later in life as well. Sometimes people also have a genetic predisposition to COPD, and poor nutrition can also cause it. There's an unknown link between those, and age also predisposes you for developing COPD later in life. So next question is, do I have COPD? So MMRC and CAT scoring systems are often used as a diagnostic tool and to also assess current symptoms of COPD. These tests are not frequently used to diagnose. There's other tests such as like lung function tests that I don't talk about in this webinar, but if you want to know more about them, I'd be happy to answer any questions. They are frequently used to these are frequently used to assess your symptoms and the severity in order to guide treatment. So the MMRC score evaluates the severity of your shortness of breath, and the CAT score measures severity of your symptoms and your risk for COPD exacerbation in the future. So I'll go into those right now. So MMRC is, like I said, the grading scale of your shortness of breath. So a grade 0 means that you only get breathless when you're exercising really hard. So you're running on the treadmill or you're doing an intense workout. A grade 1 MMRC score means on level ground, you're walking, on a grade 1 score is that you get short of breath when hurrying on level ground or walking up a slight hill. A grade 2 means that on level ground, you're walking slower than people of the same age because you're getting breathless, or you have to stop for breath when walking at your own pace. A grade 3 is that you have to stop for breath after walking about 100 yards after a few minutes on level ground. And grade 4 is that you're too breathless to leave the house or when you're dressing. So grade 4 is really taxing on your everyday life and really makes it difficult to conduct everyday activities without help. So a CAT score, like I said, kind of assesses your overall symptoms. So it's scored on a scale from 0 to 5. And so I'll go through the things on the left. So it says, I never cough, and then I cough all the time. So you would rate that on a scale of 0 to 5, 0 being that you have never had a cough, and 5 being that you have a cough all the time, and kind of rate that somewhere in the middle. So other ones are you have no phlegm in your chest at all, or you do, your chest doesn't feel tight, or your chest feels very tight often. When you walk up a hill or one flight of stairs, you're not breathless versus you are very breathless. And I'm not limited to doing any activities at home, or I am very limited to doing activities at home. And I am confident leaving my home despite my lung condition, or I am not confident leaving my home because of my lung condition, whether that be about embarrassment of not being able to walk or physically not being able to carry out everyday activities outside of your home. Next would be that you sleep soundly. Last would be that you have lots of energy. So a lot of people with COPD, like I mentioned earlier, have a lot of fatigue. A lot of them also have a lot of sleep disturbances because of their breathing problems. So how does COPD actually impact patients? So like I mentioned earlier, a COPD exacerbation often requires hospitalization. So exacerbations, like I said, always are basically worsening of your COPD symptoms. So oftentimes that's a change in your mucus production, an increase in the amount, or a change in the color. You're noticing that you're coughing more, or you have more shortness of breath in a pretty small time frame. So that's pretty much code, if you will, for a COPD exacerbation. And so oftentimes those are triggered by environmental factors, such as it could be triggered by pollen, much like asthma is, or perfume, or most commonly they're triggered by pneumonia. So if you have a lung infection, that can trigger COPD exacerbation. And oftentimes with pneumonia, you will already be hospitalized. So it really does require frequent hospitalizations. You also have a reduced ability to do everyday activities. So whether that be dressing yourself, walking outside, walking your dog, cooking dinner, it can affect, especially in later stages of the disease, it can really affect your ability to do everyday activities on your own. It often requires frequent outpatient physician visits to assess your symptoms, make sure you're okay, things like that. And oftentimes patients have a complex medication routine to manage their symptoms. So that's something I'll talk about a little bit later. I'll describe to you how that can really be poorly impactful in a patient's life. And lastly, the economic burden on both patients and the healthcare system. So like I said, this complex medication routine and frequent hospitalizations cost a lot of money, not just for the healthcare system, but more importantly, the patients, because it acts as kind of a barrier to their care and their well-being. So what happens if I am diagnosed with COPD? So before this all happens, your physician has developed a diagnosis of COPD based on your past medical history. So your history of your cough, history of mucus production, history of fatigue, wheezing. Doesn't have to include all of those, but those are the most common. And also your current lung function. So like I said, your physician will basically just give you a series of, they call them pulmonary function tests, to help them aid their diagnosis. And if you have COPD versus asthma, so that will be worked out before you're diagnosed with COPD. So COPD symptoms are manageable, and the best way to manage symptoms is to stop smoking if you are a current smoker. Like I said, smoking is the #1 cause of COPD, and as I'll get to in a second, it really is very helpful in slowing progression of the disease as well. So other things you can do is to stay active, whether that be going on short walks every day or playing with your dog for 10 minutes a day, getting out of your chair. That really helps to maintain your lung function, keep your lungs very healthy, for a healthy prognosis. So also you can ensure that if you ensure that you're taking your medications as prescribed, you can prevent future exacerbations, then reducing hospitalizations. It's very helpful in managing your symptoms. And also eating a healthy diet has really been demonstrated to help reduce exacerbations of COPD and also improve long-term prognosis. Unfortunately, with COPD, you'll also be more susceptible to colds and other respiratory illnesses. So it is imperative to stay up to date on vaccinations. Like I said, oftentimes pneumonia is a big cause of hospitalizations in people with COPD. So if you just stay on top of your vaccinations, it will reduce the likelihood that you contract pneumonia, and therefore reduce exacerbations. So yeah, I hope that all makes sense so far. Like I said, if you guys have questions, please put them in the chat. So now I'm going to get into the disease course of COPD. So most frequently, the best thing is to detect COPD early. So early detection is key. And like I mentioned last slide, lung function tests upon initial symptoms in patients who are at risk will help to detect these early symptoms and detect COPD early. There was one study that demonstrated that 85% of patients with COPD came to their physician with a respiratory symptom 5 years prior to diagnosis. So just because you have these symptoms obviously does not mean that you have COPD or you will develop COPD. But it is important to make sure you're following up with your physician and maybe keeping a monitor of your own symptoms, just to monitor if they get worse or how they change throughout the years. Early diagnosis is also linked to better outcomes, and like I had mentioned, reduced hospitalizations for exacerbations, and also long-term mortality. And like I had also mentioned earlier, exacerbations of COPD are a frequent cause of hospitalization in any stage, due to exposure to irritants, or sometimes it just happens for an unknown reason. So I'm going to kind of go through this picture here on the left, understanding the stages of COPD. So as you can see, the bright green lungs say mild COPD. So this kind of, if you have mild COPD and you're just diagnosed with COPD and they're like, okay, well, it's mild, try to smoke or try to begin smoking cessation or exercise more often just to increase your lung flow. What basically your disease entails is a mild limitation of airflow. So you're not going to have too much shortness of breath, but you probably will have some. And you'll also have a chronic mucus production and cough. It's possible, it's likely, but it's not a 0% chance. So you will have some of those symptoms. And as your COPD progresses, moderate COPD, so that's increased limitation of airflow. So you'll have a little bit of shortness of breath, a little bit more shortness of breath, a little bit more chest tightening, especially when you're on exertion. So that just means when you're exercising, when you're walking, you'll have more breathlessness then. Chronic coughing and mucus production, and patients always usually seek medical treatment first during this time. So in the bottom left where it says severe COPD, when your COPD is severe and it pretty much your airflow is limited a lot, you'll have pretty severe shortness of breath, and your fatigue will also get worse. Fatigue is probably worse because you can't get enough oxygen into your body, making you tired. Limitations to daily activities. So like I said, you won't be able to cook as you could before, maybe like dress yourself. And you'll also experience a lot more exacerbations of COPD. And this can have a severe impact on your quality of life. And in very severe COPD, as you see in the black lungs on the bottom right, you'll have a severe reduction in airflow, which may affect the heart and the circulatory system. And you'll have a noticeable negative impact on your quality of life. You may be hospitalized, and you'll have potentially life-threatening breathing difficulties, and you may need to be on oxygen therapy. So, yes. Okay. So for goals of treatment, what we say is that we like to prevent and reduce exacerbations of COPD. As I said, they're expensive and nobody likes being in the hospital. So that's what we try to do when we're talking about treatment. We also want to improve quality of life. We want to relieve your symptoms, improve your exercise tolerance. So making sure you can go longer in your walks, and improve overall health status. We also want to prevent progression of the disease. So what treatments options are available? So not that smoking cessation is a treatment, but smoking cessation is very important in preventing the progression of COPD. So smoking is the leading cause of COPD worldwide, and smoking cessation can prevent progression of the disease and may even allow some previous lung function to be regained. Smoking cessation improves mortality rates in 50% of patients, and a successful approach to quitting smoking includes both medications and counseling. So as you can see on this chart, right, patients who have COPD are in this yellow line right here, patients who smoke and have COPD. The orange line at first is just patients that smoke. This more teal line, I'm not sure if you guys can see my cursor, but this teal line is patients who stopped smoking at 45 years of age and ended up with moderate COPD. However, the red line below is patients who stopped smoking at the age of 65 years. So as you can see, their COPD progressed significantly more than those who stopped smoking 20 years earlier. So ultimately, it really slows your progression, and slows your progression, and it'll help mortality in the end, because it'll be either disabling or unfortunately it could cause death. So what treatment options are available in terms of your medications? So several medications have been developed to manage symptoms of COPD. However, no single medication or combination of medications has currently been approved to reverse COPD or permanently restore previous lung function. So current therapies are inhalers. They're used to control short-term exacerbations for the most part. They also prevent exacerbations if used every day. So typical inhalers are bronchodilators and corticosteroids, and they can be long or short acting. So for short-term exacerbations, oftentimes you'll use a short-acting bronchodilator just to increase the size of your airways. And a corticosteroid is used long-term to reduce overall inflammation so that you don't get an exacerbation. And that is typically taken every day. And then we have a long-term inhaler, a long-term bronchodilator. So that is typically taken at the same time as a corticosteroid inhaler, again, just to prevent an exacerbation versus cure an exacerbation right then. We also have oral medications. So oral medications include corticosteroids and general anti-inflammatory drugs, drugs that reduce the mucus that has been produced in your lungs, and antibiotics to prevent infection. So the oral corticosteroids also work as kind of like the inhalers do to prevent future exacerbations of COPD, and to reduce inflammation in the lungs as well. The anti-inflammatory drugs, some of them have a little bit of a different mechanism, but ultimately they do the same thing. They reduce inflammation. So yeah, so some of these are inhalers on the left, and their common drug names are Respligin, Xolair, Ventolin, and Duolin. I'm bad at pronunciation, but some of these are very common inhalers to be prescribed as a COPD patient. So using your COPD medications, it is very important to use COPD medications as prescribed. So most medications will be used daily. And then, like I mentioned earlier, the short-acting inhalers are often just used as needed. So if you feel like you're going to have an exacerbation, you're just going to kind of take that short-acting one, and it'll help you breathe better in that moment. And in order to prevent those exacerbations in the first place, it's important to take your corticosteroids, your long-term bronchodilators too. And many COPD medications should be taken to prevent exacerbations, so should be taken daily, not just as needed. And please make sure to confirm with your provider or your pharmacist that you are taking these medications correctly, as that is a very important part of how your disease symptoms are managed. So here's a general guide for COPD management. Keep in mind that based on your personal symptoms and your disease, your physician will most likely prescribe something different. This is kind of just a general framework that we like to look at when we're talking about diagnosis of COPD. So in the yellow at the top, it says that all patients are educated on smoking cessation, become vaccinated, and begin a regular exercise program upon their first diagnosis of COPD. You don't have to stop smoking cessation, but like I had demonstrated earlier with that graph, it does help to prevent progression of the disease. And then secondly, we almost often give a short-acting dilator to prevent, or short-acting inhaler to prevent acute in the moment exacerbations of the disease. So on the left, you see the green boxes are kind of what your symptoms are. So all the way on the left here, it says no shortness of breath and strenuous exercise and less than 2 exacerbations per year of COPD will lead to short-acting inhaler used with exacerbations. And in more medical terms, that is called a SABA. It's called it stands for short-acting broncho. And I'm not sure what the A stands for actually. So yes, beta agonist. I'm sorry, that was short-acting beta agonist is what SABA stands for. So that's what we would start with if you have less than 2 exacerbations per year and overall your lung function is pretty good. However, down here in the orange, it says if your symptoms continue with the use of a short-acting inhaler, a long-acting inhaler will be used. And that was a LABA, a long-acting beta agonist, just if you want technical terms. So in the middle is more severe symptoms. So if you notice that you walk slower or you're more breathless, that you have more shortness of breath than individuals of the same age, maybe your spouse or one of your friends, or your CAT score is greater than 10. So we had talked about the CAT score earlier. Physicians will often give you a long-acting inhaler to take every day. So whether that was most likely just going to be in the morning, you're going to take your long-acting inhaler and also be given some pulmonary rehabilitation. And these are just with specialists, typically in outpatient settings. And in the orange below, again, if you have persistent symptoms, then 2 long-acting inhalers will be used and a corticosteroid inhaler to prevent long-term inflammation. And then all the way on the right, it shows in the green, it says no shortness of breath and strenuous exercise and more than 2 exacerbations per year. So if you function normally every day, but you are having more than 2 exacerbations per year, your doctor down here in the blue will maybe start you on a combination of a long-acting inhaler or a combination of a long-acting inhaler and a corticosteroid inhaler to prevent exacerbations. And then again, this arrow is pointing from this last blue square on the right, going down to the orange. So the same thing, if your symptoms are persistent, if you're having shortness of breath, if you're not having shortness of breath and you're having greater than 2 exacerbations per year, your physician is going to put you on 2 long-acting inhalers and a corticosteroid. And like I mentioned, this is just a framework and not all treatment regimens are going to be this way, but it will look somewhat like this depending on how your symptoms are and your personal disease state. So what are some complications of COPD? So life-threatening lung infections are one of the worst complications of COPD. So most often happens in severe COPD when you can't breathe properly, you can't get mucus out of your lungs. A lot of times that mucus is almost a breeding ground for like bacteria and viruses to get into your lungs. And those often require hospitalizations. Also a pneumothorax, so that is just air in your lung, can often happen from chronic COPD or COPD over a long time. You can also get right-sided heart failure because what happens is when you don't have a lot of oxygen to your lungs, the blood vessels in your lungs start to constrict and get really tight, and the blood kind of backs up into the right side of your heart. So they call that right-sided heart failure because eventually your heart gets really tired and it doesn't pump as well, and that fluid can back up into the rest of your body. It can also cause respiratory failure because you're not getting enough oxygen, and also lead to COPD exacerbations, as we had talked about before. So COPD is a very complex disease, and it can be difficult to manage symptoms. And so I'm going to discuss the importance of shared decision-making in COPD. So shared decision-making is a form of communication between a healthcare provider and a patient in making decisions regarding health-related matters. COPD is a complex disease with complex, ever-changing management of symptoms. Giving patients the ability to make a reasonable and attainable decisions about their own health is important to achieve their health goals. So if you are talking with your physician and you say, oh, I can't take 2 inhalers a day. Well, your physician would work with you to kind of work out a deal per se about what is best for you and what is also attainable for you. And actually a recent study found that patients and physicians in COPD with COPD who engaged in shared decision-making after hospitalization maintained all discussed regimens in comparison to those patients that did not discuss, who did not engage in shared decision-making. So oftentimes it is even better for us. So in this study specifically, if a patient and a physician engaged in shared decision-making after the patient was in the hospital, they all had better outcomes over a couple of years versus the patients who did not. Almost all the patients who did not engage in shared decision-making were not adherent to their medications at their next follow-up in a couple of years or months. So yeah, and this is something to discuss with your doctor if you don't feel like your treatment regimen is something that you can handle. So a couple of takeaways from this presentation. COPD is a chronic disease of the lungs and is most often due to smoking. Smoking cessation is key if the patient is an active smoker in reducing mortality and progression of the disease. COPD symptoms are manageable with our current therapies, and treatment of COPD changes as disease progresses. And a sustainable treatment plan is the best way to ensure adherence to treatment. Any questions? Okay, well, thank you. Like I said, if you guys have any questions, I'll put my email in the chat, but just a quick, I just want to say thank you to everybody who came today for this series, and a special shout out to Jasmine and Kavita for organizing this event, and all of the NEOMED faculty members and marketing and communication our department at NEOMED in helping to market this series and all of that. So they were really integral in helping all of us and all of you come to this. So I really appreciate everybody's participation.